Okay, so now we're going to move on to gas pressures in the alveoli. Time-wise, we're actually much further down this list than it looks like because these top two topics took a bit more time. Okay, so what determines gas pressures in the alveoli? There's a couple of things on this slide to pay attention to. So first is this terminology here. So we've got a P, a subscript, and then O2. So the P means you're talking about the pressure. And in this case, you're talking about the partial pressure of oxygen. The I means inspired. So we're talking about the partial pressure of inspired oxygen, which basically means the partial pressure of oxygen in the room that you're in. So as we talked about before, the partial pressure of oxygen in the room that you're in is about 160 millimeters of mercury, and the partial pressure of carbon dioxide in the room that you're in is 0. There's essentially no carbon dioxide in the room. So you have alveolar ventilation taking place. Alveolar ventilation is the rate at which you're moving air in and out of your alveoli. You should probably read a little bit. Alveolar ventilation is a little bit less than your total ventilation, and that's because of the dead space airways up above here. So that's something you can read about, why alveolar ventilation is a little bit less than your total ventilation. Anyway, so you have alveolar ventilation, and while you're breathing, there's some things going on. First one is the air is getting humidified, so water is taking up some more of that 760 millimeters of mercury of total pressure. Carbon dioxide is diffusing from the pulmonary, it's called the pulmonary artery. Carbon dioxide is diffusing into the alveoli, and oxygen is diffusing out. So it's not hard to imagine that in the alveoli, the partial pressure of carbon dioxide will be higher, and the partial pressure of oxygen will be lower because water's taken up some of the space and carbon dioxide's taken up some of the space and oxygen's leaving. So if we look in the alveoli, the partial pressure of oxygen in the alveoli, so the big subscript capital A means alveoli, the partial pressure of oxygen in the alveoli is about 100. The partial pressure of carbon dioxide is about 40. And I guarantee that it's pretty close to that in all of you, unless any of you have any significant respiratory diseases. And the reason for that is because you like it like that. The partial pressure of gases in the alveoli very heavily influences the partial pressure of gases in the vessels draining the lungs, the pulmonary veins draining the lungs, which then goes down into your systemic arteries, and that's where your things called chemosensors, which we'll talk about later, are. And if your partial pressure of oxygen, carbon dioxide get much different than that, your chemosensors sense that, and you get very uncomfortable. So you can imagine that the more you breathe, the faster you're breathing, the more carbon dioxide you're going to blow out into the room, and the more fresh oxygen you're going to bring into the alveoli. So it turns out that alveolar CO2 pressure is directly inversely proportional to your alveolar ventilation. So if you were to right now double your alveolar ventilation, your alveolar CO2 would fall to 20. If you were to half your alveolar ventilation, breathe half as much as you are right now, your alveolar CO2 would increase to about 80 millimeters of mercury, and you would be profoundly uncomfortable. So we can regulate what our alveolar gas pressures are by changing the level of ventilation. So if you have a patient, for example, who's breathing less, alveolar CO2 will increase and alveolar oxygen will decrease. Okay, now that we've looked at how ventilation can influence the gas pressures in the alveoli, we'll look at how alveolar gas exchange actually takes place as a result of those gas pressures. So here we are in the alveoli where there's an alveolar oxygen pressure of 100 millimeters of mercury and an alveolar carbon dioxide pressure of 40 millimeters of mercury. The blood that's flowing through the lungs, through the pulmonary arteries, is actually called venous blood. That's because it's blood that has already taken part in gas exchange out in the cells in your body. But when it comes into the lungs, it now travels along an arterial system, even though we refer to it as venous blood. So the venous pressure of oxygen is usually, in most people at rest, about 40. So it's taken part in gas exchange. The oxygen pressure is quite low. The carbon dioxide pressure is higher than in the alveoli because this blood has taken part in gas exchange and the cells have released CO2 into that blood. So now you have blood flowing past the alveoli with a partial pressure of oxygen of 40, partial pressure of carbon dioxide of 45, and it's exposed to the alveolar air where you have a higher partial pressure of oxygen and a lower partial pressure of carbon dioxide. So this figure here illustrates what happens to the partial pressure of gases in the blood as it flows past the alveoli. So it's starting on the venous side here and ending on the arterial side here. So if you start with oxygen, it arrives with a partial pressure of 40 right here. Very rapidly it equilibrates with the air in the alveoli, reaching a partial pressure of close to 100, probably when it's only 25% of the way through that capillary bed. And then when it gets to the other side of the alveoli, it's got a partial pressure of oxygen of 100. Carbon dioxide arrives with a partial pressure of 45, probably equilibrates even quicker because CO2 is a more soluble gas, and leaves with a partial pressure of 40. So the blood's arriving with these partial pressures and leaving with the same partial pressures of gases that it sees in the alveoli. So you get very rapid equilibration. Then, when this blood finally makes its way through the left side of the heart and out into the systemic arteries, it's actually changed a little bit. So if you look here, when the blood was just at the end of the capillary bed, the oxygen pressure was 100. In your systemic arteries, it's down to 95. That's not because the blood is getting used up on the way through the arteries. The reason that the arterial oxygen pressure is less than the alveolar oxygen pressure is because you get other bloods mixing in with the blood before it gets to the arteries. So you've got blood that actually flows through the left ventricle, which is adding venous blood into the arterial system before you get down to your systemic arteries. You've got some blood draining from the lungs that's putting venous blood in here. So the alveolar oxygen pressure and the oxygen pressure in the blood right here is more than out in the systemic arteries because you've added some venous blood here. That actually has an effect on the CO2, but it's much harder to see that. The reason for that is mainly due to the shape of the oxygen hemoglobin dissociation curve. So the tiny difference in CO2 pressures and a much bigger difference in oxygen pressures. So you might remember from the last slide, I mentioned that alveolar carbon dioxide pressure was directly inversely proportional to ventilation. So that fact, along with the fact that there's very small differences between alveolar carbon dioxide pressure and arterial carbon dioxide pressure, means that arterial blood gases and looking at the CO2 pressure is the best test of whether the patient is adequately ventilating. So if you take an arterial blood gas from a patient and you see that the CO2 pressure is around about 40, maybe between 37 and 43, then you know that that patient is ventilating adequately. If it's greater than that, if it's up at 50 or 60, or in some patients even up as 80, you know that that patient has alveolar hypoventilation. They're not breathing enough. If it's lower than that, you know that they're hyperventilating. You can look at oxygen pressures in arterial blood gases for all kinds of other reasons, because a lot of the diseases that you'll talk about, and we'll look at some of them as we go through the next few slides, can lead to changes in arterial oxygen pressure. All right, so let's think about what would happen if you went to altitude. If you went to altitude, the barometric pressure is lower up there, and the partial pressure of oxygen is a lot lower. So the inspired oxygen pressure that you're breathing in is low. So you end up with a lower alveolar oxygen pressure, maybe 60. You keep alveolar carbon dioxide pressure roughly the same because, like I said before, people have chemosensors out here, and if you sense a change in your carbon dioxide pressure, you get uncomfortable and you change how much you're breathing. So even though you've gone up to altitude, you tend to breathe in a way that keeps your alveolar carbon dioxide pressure roughly the same. But now the alveolar oxygen pressure is only 60. So if we look at what's happening, the venous blood that's coming back still has a venous oxygen pressure of 40. Venous carbon dioxide pressure is 45. You still get nice equilibration, except that the alveolar oxygen pressure is so low. So when the blood leaves on this side of the alveoli and it goes out to the systemic blood, you have a very low arterial oxygen pressure of 60 and a normal arterial carbon dioxide pressure of 40. So going to altitude is one of the simplest ways to become hypoxic. There's nothing wrong with your respiratory system. The alveoli is working fine, the blood supply is working fine, you're breathing appropriately, you've got your carbon dioxide level exactly where it should be, but you're hypoxic, and that's just because there's not enough oxygen coming into the system. What would happen if you didn't breathe enough? So now the alveolar carbon dioxide pressure is 80 because you're hypoventilating. You're just not breathing enough to blow the carbon dioxide off. The alveolar oxygen pressure is now lower because you're not bringing oxygen in at the same rate you were before, and carbon dioxide is taking up more of the space. So now if you look at what's happening, as the venous blood arrives, the venous blood arrives with an oxygen pressure of 40, which fully equilibrates as it passes the capillary, but again, it's not going to the same high level as in a healthy person because you're not breathing enough, and the alveolar oxygen pressure is 60, so it's plateauing off at about 60. Carbon dioxide fully equilibrates, but it's equilibrating at a much higher level because you're not breathing enough. So now when you look at arterial blood, the arterial oxygen pressure again is low, you're hypoxic, but there's a big clue here for why you're hypoxic, and that's because the arterial CO2 pressure is high. That, like we said before, absolutely tells you that this patient is hypoventilating. They're not breathing enough, that's why the CO2 is high, and that's likely why the oxygen pressure is low. What would happen if there was a barrier to diffusion? Okay, so now you're breathing perfectly normally. You've got alveolar oxygen pressure at 100, exactly where you want it. Alveolar carbon dioxide pressure is at 40, exactly where you want it. Venous blood is coming back, but there's a barrier here. So now then, when the blood flows past the alveoli, rather than rapid equilibration, it takes the oxygen pressure considerably longer time to equilibrate because there's a thicker barrier there. So now the blood's arriving with a partial pressure of 40. By the time it gets to the other side of the alveoli, it's only maybe got up as high as 60. It would have got to 100, but it wasn't time, and there was a barrier to diffusion. So now the blood leaves again with a low partial pressure of oxygen of about 60. The diffusion barrier can have an effect on CO2, but it's usually quite a lot smaller. One, because CO2 is more soluble, and again, also due to the shape of the oxygen hemoglobin dissociation curve. It has a larger effect. So when you are looking at blood gases, and when you look at blood gases in the patient you see in the tutorial problems, think about reasons why there might be hypoxia, because several of the patients will have a low arterial oxygen pressure, and there can be different underlying reasons. There can be diffusion barriers, there can be hypoventilation, they could be at an altitude. So think about why they're hypoxic. Hypoxic is a common outcome, but there's several underlying mechanisms, and that's one of the interesting things in respiratory physiology, is to think about what the clues are for why that patient happens to be hypoxic. So there are several diffusion problems. That's where you've got a thickening of the diffusion barrier. You can have what I call sort of inflammatory ones. Heart failure is not really inflammation, but you've got a backup of fluid into the heart that can widen the diffusion barrier. You can have an infection with pneumonia, so inflammation in the alveoli itself, that can widen the diffusion barrier. You can have chronic structural change to the alveolar tissue with interstitial lung disease, with emphysema, that can again give a widened diffusion barrier. These may not be apparent at rest, so you can have patients who aren't hypoxic at rest, but they still have a barrier to diffusion. But then maybe if they start to exercise and the blood's flowing quicker through the heart and you've got less time for equilibration of those gas pressures, then a patient who wasn't hypoxic could suddenly become hypoxic with fairly mild levels of exercise. So that's something you might want to consider when looking at patients. If they don't seem hypoxic sitting at rest, get them up and have them walk around the corridors in the clinic and see if they become hypoxic, and that might be an indication that there's a widened, thick diffusion barrier.